Hello everybody and welcome to the second webinar of our sports medicine webinar series. We're very happy that you were able to join us today. The agenda that we are following today, we're going to have a 20-minute presentation by Dr. Christiano, and then we're going to have a Q&A of around 10 minutes. So we would like you to please send us your questions via the chat feature that you'll see on the right-hand side of your screen. We will be collecting questions throughout the talk, and we'll be answering as many of them as possible by the end of the session. For those of you who are not familiar with us, the New England Baptist Hospital is a specialty hospital. It's actually the only hospital in the New England area that is specialized exclusively in orthopedic care. We in fact have the highest or largest volume of orthopedic cases in Massachusetts, and that combination of a specialization with a volume of cases gives us really a unique knowledge and unique expertise in orthopedics. And that's the reason why we're here today. We really want to share this knowledge and expertise with all of you, and hopefully give you valuable information that will help you prevent sports-related injuries or know the treatment options if you actually get injured. The topic of the day is what all parents need to know about common youth sports injuries. And we're very lucky and very excited to have with us today Dr. Arthur Christiano. He is with Orthopedics New England Group, and he's also an orthopedic surgeon here at the New England Baptist Hospital. So a quick bio, Dr. Christiano, he's a board-certified orthopedic surgeon and is also certified in sports medicine. He completed medical school in New York Medical College. He then went to do his internship and his residency in orthopedic surgery and pediatric orthopedic surgery at Monmouth Medical College and the Children's Hospital of Philadelphia. And in addition to that, he has a fellowship in sports medicine from Thomas Jefferson University. He has received a few awards in the past few years that are definitely worth mentioning. He received the Vitals.com Top 10 Doctor Recognition, Vitals.com Patient Choice Award, and the Compassionate Doctor Recognition Award. In addition to that, Dr. Christiano is affiliated with a number of colleges and institutions in the area. He works closely with the Framingham State University, the athletic teams, the Boston Junior Bruins, Medfield High School, and Medway High School. So without further delay, here with us is Dr. Arthur Christiano.
Well, thank you very much. I'd like to thank New England Baptist Hospital for hosting the webinar, as well as for anybody out there tuning in. I always find these webinars and talks somewhat challenging to give just because there's such a wide experience level with some of the participants. This is taken on a little bit of a broad topic, what all parents need to know about common youth sports injuries. So it's really no secret that over the last 40 years there's been a marked increase in young athletes participating in sports. And there are really a lot of reasons for this. One of the ones that I like to point to as a catalyst for this growth was back in 1972 with the passage of Title IX. What Title IX represented, it was an educational amendment that basically said that it prohibited colleges and universities from discriminating in educational programs of any kind, particularly if they were receiving federal funding. And that applied to their athletic departments as well. And so it motivated a lot of these colleges and universities to develop women's athletic programs. And the net effect was that it opened up a lot of educational athletic opportunities for young women to participate at the collegiate level. As a result of that, there was a trickle-down effect to both the high schools and elementary schools in terms of program development and participation of young women athletes. And so I think it engaged a population that prior to that had been relatively underrepresented in athletics. So although there's no formal census on a year-to-year basis as to who's participating in sports and who isn't, most people will estimate that greater than 21.5 million children between the ages of 6 and 18 participate in sports every year. In one survey in 2011, they polled 18-year-old students, and they found that 87% of male students and 82% of women students stated that at some time in their childhood they participated in an organized athletic program. And so what we're dealing with is a very big problem. And so the unfortunate reality is when you have an increase in this in participation to this degree, you get an increase in injury rates. And so what I wanted to tackle was basically two common athletic problems. Rather than lay out a laundry list of a variety of different issues, I wanted to focus on two common problems. And I think it's important to do so for a variety of reasons. One, you'll most likely encounter these. You probably have a friend, a family member, or even yourself that has sustained one of these two injuries. They are ankle sprains and traumatic shoulder dislocations. And oftentimes I have people coming to my office simply for questions as to where to go from here or what to do next. And so hopefully, with a general understanding of these two problems, you'll be able to initiate some of the first-line treatments for ankle sprains or shoulder dislocations and decrease the morbidity related to them and hopefully accelerate the return to sports. So how common are ankle sprains? The ankle sprains are very common. The incidence in the general population is 7 out of every 1,000 people will sustain an ankle sprain. What that translates into across America is about 25,000 ankle sprains per day. Now, not all these ankle sprains are related to athletic injuries, but in terms of the athletic population itself, 40% of athletes or athletic injuries are attributable to ankle sprains. Some sports are more high risk than others. For instance, basketball has a 45%. 45% of all basketball injuries are ankle sprains. Soccer is another one, as is football. And so it's important to come to an understanding of what to do, because in all likelihood, at some point in your athletic career, this may happen to you. Another important aspect of why to talk about ankle sprains is that there are several studies that indicate between 1/3 and 2/3 of people who have an ankle sprain will go on to have continued symptoms of pain, swelling, and potentially instability. So if we can identify them early, initiate the appropriate treatment, then hopefully we can lessen these long-term effects. So let me start by backing up a bit. I think to understand any sort of injury, it's important to understand the anatomy. And when we're talking about ankle sprains, they come in a variety of different kinds, but the ones that we're going to deal with or talk about today are the classic low ankle sprains. That's a disruption or tearing of the lateral ankle ligaments. So what is a ligament? A ligament is a thick band of connective tissue. Think of it as like the human equivalent of a rope. It attaches one bone to the other and provides some motion, but hopefully not excessive motion. And in a sprain is a tearing of that ligament. The ankle joint itself gets its stability from two different areas. It gets it from its dynamic forces, the muscles and tendons that cross the joint to help stabilize it, as well as the static stabilizers. The static stabilizers are made up of both the bones and the ligaments. The three main bones of the ankle are the tibia, the fibula, and the talus. The tibia and the fibula essentially form an inverted U with the talus riding in the center of that U. The ligaments, there are three, two on the outside, the anterior talofibular ligament and the calcaneofibular ligament, and one on the inside called the deltoid ligament. So what is the common mechanism by which ankle sprains occur? Typical mechanism is what we call plantar flexion and inversion. It's a fancy way for saying the foot and toes go down and in, much like in the picture that you see on the right-hand side of your screen. As a result of this, the ankles are stretched and torn, and people experience pain. The diagnosis is usually very straightforward. History is usually enough to confirm that an ankle sprain has occurred. And these days, where everybody has an iPhone or some sort of camera, a lot of times you can actually patients will actually bring in video footage of what happened, and that helps to understand what exactly happened and diagnose the problem. One of the most concerning things that bring people into my office for an ankle sprain is the fact that oftentimes it's associated with an audible pop or tear, and that can be very unnerving to people. They think, oh, I must have ruptured something. Swelling develops almost immediately because there's a blood vessel in and around in the ankle ligament, and patients oftentimes have difficulty weight bearing, and that gets them either into the emergency room or into the physician's office. In terms of the classification, it's important to classify it just based on its severity, but there are multiple different classification systems out there. The simplest way to think about it is if the classification is, if it's a grade 1, it's typically a mild one, a grade 3, more severe. And with the more severe sprains, you have more swelling, more pain, and more difficulty weight bearing. In terms of the management, the overwhelming majority of these can be managed non-surgically. In the initial phase, the key is control the swelling. Essentially, and we employ the principles of RICE, which is an acronym for rest, ice, compression, and elevation, with the two real key components being ice and elevation above the heart level. And what you're really trying to do is break the progression of the disease. When you have an injury, swelling develops, that causes an increase in pain and subsequent stiffness and weakness. And so what you want to do is minimize the impact of that swelling, and so hopefully the pain is lessened and the disability in terms of the stiffness and weakness is mitigated. Once you get over the initial hurdle, we often use an anti-inflammatory medication to control both the pain and swelling, and then we progress them in a physical therapy program. The good news with ankle sprains is in general that you're able to put full weight on them despite the pain, and then gradually progress from regaining the range of motion to regaining the strength. What are some of the criteria that we use for when somebody can return to sports? Well, I think severity obviously bears on this. A milder sprain can get back to sports probably a little bit quicker than a more severe sprain. The typical timeline is somewhere in the order of 2 to 6 weeks. This also can be dependent on the sport. Someone who sprained their ankle and is a cyclist or a swimmer may be able to get back a little bit quicker than somebody who is involved in more of a twisting and pivoting sport like soccer or football. Our goal when allowing somebody to return to sports is make sure that they're pain-free, make sure they have full strength and full range of motion, and that they have no residual instability episodes. Well, one of the common questions we get is how can an ankle sprain be prevented? The most important thing by far is keeping the ankle in good shape. And what that means is keeping the muscles that cross the ankle joint strong. There are a variety of different programs. Most of these programs employ balance and proprioceptive training. What proprioception is basically, if you think of it from the perspective of close your eyes and stand on one foot. Why don't you fall over? Well, there are small little nerves that are controlling your muscles to maintain that sort of balance. And as you can see in the picture on the right-hand side of the screen, the young woman is doing something with the ball, standing on an uneven surface and contracting her ankle muscles, the muscles around her ankle joint, to stay supported on that ball. The other two common questions we get are with regard to taping and bracing. Both of these are effective in reducing clinically significant ankle sprains. Both of them provide direct support to the ankle. And some people postulate that because they're wrapped around the joint tightly, that the proprioceptive nerves are engaged as well, further adding to the stability of the ankle. The only downside, particularly with taping, is that most of the studies indicate that taping loses 50% of its strength within the first 20 minutes. And so in the second quarter or second half, oftentimes the taping has to be redone. A couple of special cases as it relates to ankle injuries. Now, with ankle sprains, generally, these occur in skeletally mature individuals. Skeletally immature athletes are at risk for a different type of injury. These patients and athletes have growth plates, and forces, whether it's a twist or a turn, like to localize to the area of weakness, and growth plates are typically the weakest link in the chain. And so when you have somebody who's skeletally immature, and by that I mean somebody 12, 13 years of age, a lot of times these are growth plate injuries and not ankle sprains. And you just have to keep that in the back of your mind. If the swelling is more over the bony areas rather than over the areas classically associated with the ligaments, then you may want to seek medical attention a little bit earlier. The other difference is a high ankle sprain. This is a common, we've been talking about the low ankle sprains. High ankle sprains is a totally different animal and a totally different injury. This involves the ligaments that keep the tibia and fibula together. These have a much more unpredictable outcome and a much longer recovery time. The second topic I wanted to take on was traumatic shoulder dislocations. Much like ankle sprains, these are also very common injuries. The overall incidence, though, is much harder to say. These injuries often can go unrecognized or underreported because the shoulder can spontaneously reduce or pop back into place. Many studies have tried to determine what the true incidence is, and they came up with this concept of athletic exposures. And athletic exposure is how often you play a sport. So if you practice once a day, that's one athletic exposure. And so they quantified the overall rate of traumatic shoulder dislocations in sports as 0.12 dislocations per 1,000 exposures. And so obviously that's confusing. The easiest way to think of it is if you had a team of 50 athletes practicing 5 days a week, that's 250 athletic exposures. And over the course of a 10-week season, that's 2,500 exposures. And so you can expect one dislocation for every essentially 4 teams. And I'm talking about a primary dislocation, not a recurrent dislocation. There are certain high-risk sports that are involved. Football is always your number one, with wrestling and hockey a close second. The typical mechanism, the typical injury occurs more often player-to-player contact or player to some sort of inanimate object like a floor or something. So what is a dislocation? With shoulder dislocations, what we're talking about is the ball and socket joint. The ball is forced out of the socket and either stays out of the socket or requires a reduction or can spontaneously reduce. And this is different than a shoulder separation, which is also another common shoulder problem. Shoulder separation is an injury to the point of the shoulder rather than to the ball and the socket joint. The majority of shoulder dislocations are anterior, meaning the ball pops out the front of the shoulder. More than 90% of shoulder dislocations of a traumatic origin occur in this direction. The typical mechanism is abduction and external rotation. So essentially bringing your arm up and overhead. A typical scenario where somebody would sustain a shoulder dislocation is a quarterback dropping back to pass, having his arm in that cocked position, and then getting hit on the front part of the shoulder. Another way would be if a wrestler is getting thrown to the ground and his arm is up and about and gets forced back. Once again, I'd like to take a step back and focus on the anatomy prior to moving forward. Much like the ankle, there are 2 ways that the shoulder is stabilized. There are the dynamic restraints, which are the rotator cuff muscles and the scapular stabilizing muscles. They form a cuff around the ball to keep it centered in the socket. The static restraints are 3 structures: the labrum and the ligament, labrum, ligaments, and capsule. The labrum is a rim of cartilage around the socket. The functional labrum is to deepen the socket, much like a catcher's mitt deepens a catcher's hand so that he can catch the ball more easily. The ligaments are ropes which span from the ball to the socket and keep the shoulder in place, and the capsule is very similar. What damage occurs when a shoulder is forced out of the socket or dislocated? You can tear the labrum. Typically that occurs where the labrum attaches to the socket and is ripped off. You can tear the ligaments, once again being ripped more commonly off the socket side than the ball side. You can fracture the socket, or you can sustain a divot in the back of the humeral head, which we call a Hill-Sachs defect. All of these problems can lead to persistent pain and persistent instability down the road. So what is the treatment for shoulder dislocations? Well, the initial treatment, the priority and the focus is all on reducing the shoulder. And there are a variety of techniques to accomplish that. Now, unlike in the movies, this doesn't have to be some sort of heroic maneuver. Generally, gentle, steady longitudinal traction with some rotational motion to the shoulder gets the shoulder to reduce into place. This is typically reserved for a doctor, a trainer, a physician's assistant to perform rather than you having to take on that responsibility yourself. After the shoulder is reduced, x-rays are obtained to see if there are any damage to the bony structures, and the patient is immobilized in a sling. This allows us to evaluate for any sort of additional injuries, such as injuries to the rotator cuff or some of the nerves that surround the shoulder. Our primary goal, once we get over the initial hurdle of stabilizing the shoulder, is to institute treatment to minimize the risk of recurrence. This is a very large problem after sustaining a primary dislocation. We start with rest, ice, and immobilization, and the degree of immobilization is very surgeon or doctor specific. I typically immobilize my patients for 3 to 10 days and then get them in a physical therapy program as they feel comfortable to get the shoulder moving and prioritize motion first over strengthening. But there is some debate amongst orthopedic surgeons as to the period and position in which the arm needs to be immobilized. Once they start getting ready to return to sports, we start talking about concepts of bracing and where to go from here. What are some of the risks or warning signs that we look out for somebody who could potentially be at a high risk for recurrent instability? The age less than 20, males are more common than females in terms of having recurrent instability. The type of sport plays a huge role. Football, rugby, in the picture Australian rules football are all high contact sports and have a higher rate of redislocation. The number of dislocations somebody has is also important, and any sort of bone damage that was picked up on the initial radiographs. Is surgery ever needed for shoulder dislocations? The short answer is yes. If there's significant bony involvement, if this is one of several dislocation events that they've had in the recent history, if they have a high-risk lifestyle like the military, the police force, the firefighters, oftentimes being a little bit more aggressive is more appropriate in managing some of these patients. How is the surgery performed? There are a variety of different ways to do this as well. Often arthroscopic, often these days many of these procedures can be addressed arthroscopically. The first step is getting an MRI or an MR arthrogram to see exactly what's been damaged as a result of the dislocation. Often a CT scan is necessary if there's been some bony damage to the shoulder. And then if you determine that it's potentially a purely soft tissue problem or a problem with a very minor bone component, then you can address these either arthroscopically or open. And what you can see in the diagrams is the labrum being stitched back to the front or leading edge of the socket. The debate whether to do open or arthroscopic is once again more of a surgeon preference sort of thing, whatever they feel more comfortable with. When there's significant bony involvement, oftentimes that bone either has to be stabilized back into place or has to be, or a graft has to be obtained to reconstruct the bony defect that's been left behind. A procedure called the Latarjet procedure is starting to gain a lot of popularity in the United States over the last 5 to 10 years. And that's just essentially taking the front part of the shoulder called the coracoid process and augmenting any bony defect that may be present. What's the typical recovery? Well, these are typically day surgeries, so you go home the same day. You are immobilized in a sling, but often start physical therapy within a week or two to prevent excessive stiffness from setting in. The physical therapy progresses at an individual pace with usual recovery somewhere in the order of 4 to 6 months, depending on how things go. Now, how are dislocations managed in the in-season athlete? This can be a very challenging problem. I think it's really athlete dependent. You have to have an engaged patient, engaged athlete who is motivated to get better, because there is a chance the shoulder can come out again in the same season. It also relies on both the sport and the position. Contact sports or sports that require your arms to be in an overhead position are more at risk for developing recurrent instability than, for instance, cycling or something. Dominant versus non-dominant arm. Lastly, if you manage these appropriately, there's some studies indicate that you get as high as 87% chance that you can return to the same sport in the same season. Once again, with a slightly higher than average redislocation percentage. I like this. This was provided to me by my colleague, Dr. Osich. This is an algorithm which delineates how should you progress or how should you be thinking about in-season treatment. If you follow the arm to the left, you have an instability event. Radiographs confirm that there's no significant bony injury, or can confirm whether or not there is a bony injury or not. If there's a large bony defect or a large divot in the humeral head, then oftentimes surgery is a better path to address this problem. For those that strictly have a primary soft tissue component, meaning an injury to the labrum or ligaments, If this is a recurrent instability episode, I think you need to really give serious consideration to moving forward with surgery. If it's an initial instability event and near the end of the season and recovery in season is unlikely, then you have a discussion with the patient whether or not they'd like to proceed with surgery. If it's at the beginning of the season, we can progress with the rehab that we described, where it's a brief period of mobilization followed by physical therapy. The criteria that we use for returning to sports is making sure that they have full strength and full range of motion. They are able to demonstrate their sport-specific skills with no feelings of instability. Can I prevent shoulder dislocations? Unfortunately, the answer to that is no. There's no hard and fast way to prevent sustaining a shoulder dislocation. But if you maintain the rotator cuff and the periscapular muscles in good shape, maintain your flexibility, then I think that positions you as best as you can to minimize the risk. Thank you very much.
Great. Thank you very much, Dr. Christiano. That was an excellent talk and great information. We have now a few minutes to answer a few questions from the audience. So I'm going to give some of the questions to you. The first one is, I often say to my friends I have weak ankles or unsteady ankles. Are some people more prone to ankle sprains, and what can I do to prevent them?
I think some people are predisposed. Some people are double jointed or loose ligamented. Some of the kind of slang that people use to describe themselves. So with the ligaments being less appropriately tensioned, then they're putting more stress on those muscles, and so there's nothing that you can do beyond strengthening. You can use the taping, you can use the bracing, you can do the strengthening and try to address any looseness or laxity, but I would say that's probably your best option.
Okay, great, thank you very much. The other question, which I think you touched on, is which is better, taping or bracing to prevent ankle sprains?
I think, this is a common question that I get in the office, and I think they're equally effective in terms of immobilizing the ankle. But where taping stretches out within the first 20 minutes and loses 50% of its strength, I often advocate bracing simply because in the second quarter or the second half you're able to adjust it and re-secure the ankle if you don't have access to a trainer who can retape you. And so from a practical standpoint, I think bracing oftentimes is a little bit more helpful.
Okay, great, thank you. Are there any other common problems that are associated with ankle sprains that athletes should be aware of?
With ankle sprains, you can get injuries to the tendons or subluxations of some of the tendons that support the ankle, like the peroneal tendons. You can get some damage to the joint surfaces. We call these osteochondral defects that can lead to some of the residual symptoms that I mentioned before.
Okay, great, thank you. I think you touched on this one as well. This is someone who had several ankle sprains, and they wonder if they would ever need surgery. Do you ever do surgery for ankle sprain?
Yep. Surgery is indicated for recurrent ankle sprains that can't be stabilized with the traditional non-surgical approach. Sometimes, when a ligament tears, it's never quite the same, and so sometimes with repetitive ankle sprains, it's just too stretched out for the muscles to really compensate for it. And so there are a variety of different procedures where you can go in and tighten up those. It's kind of like taking in a pair of pants. You can tighten up those ligaments.
Okay, great, thanks. This is more on the shoulder. If I'm in the middle of a game and my friend has a shoulder dislocation, should I attempt to reduce my friend's shoulder or put it back in place?
Generally, I say no. If you're in the middle of Timbuktu, then maybe give it a try. But I think generally let the trainer, let the PA, let the ER physician kind of address that. Because if it's too violent a maneuver, you can do further damage, which could complicate his risk of recurrence.
Okay. And along those lines, what are the long-term problems after a shoulder dislocation that I should be concerned with?
Well, every time the shoulder dislocates, what we're really trying to preserve is the cartilage that coats the ends of the bone. So anytime two bones meet, in this case the ball and the socket, the ends of the bone are coated with cartilage. And that cartilage is a cushion, so every time the shoulder dislocates, you're banging that cartilage and potentially injuring it. And the problem is cartilage doesn't heal real well. And so what can happen down the road with recurrent instability is that you can develop arthritis in the shoulder.
Well, these are the questions that we had. Again, we wanted to thank Dr. Christiano for this excellent presentation and great information.